forum with the WHO Africa region. Now having the opportunity of hosting the Africa Health Agenda International Conference here in Kigali, and when you look at different topics being displayed in this conference, and you make correlation with what we were discussing, almost 2 years back, there is a strong linkage. In June 2017, the key topics for that conference was putting people first in the road towards UHC in the Africa context. And if you read the declaration that was made at that time, or the call for action, actually that really aligns well with the topic of this conference, which is multi-sectoral action to achieve universal health coverage in Africa. So without really taking further ado, I want to thank and appreciate the AMREF Health Africa to have chosen to partner with Rwanda to run this going to be a successful conference. Without really taking further ado, I want to welcome and thank Dr. Gitinji Gitahi, who is the Group CEO for AMREF Africa, to come and provide his welcoming remarks. Thank you.
Good morning, ladies and gentlemen. Good morning, Africa. Good morning. Well, our guest of honor and my co-chair in the organizing committee of the Africa Health Agenda International Conference and Minister of Health, Republic of Rwanda, the Executive Director and Under Secretary General of United Nations, Michel Sidibe, distinguished guests, honorable ministers, members of parliament, deputy ministers, ambassadors, partners, colleagues, we are really humbled to have you here. This is the Africa Health Agenda International Conference. It is Africa's own conference in Africa and on Africa. This is not an AMREF Health Africa conference. This is the Africa Health Agenda International Conference, convened by AMREF Health Africa. I would like to most sincerely thank the government of Rwanda, my sister Diane Gashumba, who was dancing with me at the closing ceremony of the youth conference. She's a better dancer than I, and her team for the partnership in hosting this conference. We could not have done it without the support of the government. Please give a big hand to the government of Rwanda for that collaboration. As an African platform, our role is to provide a medium for Africa's issue to emerge, to be discussed, and to be resolved. We choose different countries when we are hosting this conference. The last conference was in Kenya in 2017. This conference is in Kigali, Rwanda, at this fantastic venue. And we are still thinking about the next venue in March 2021, because this conference happens every 2 years. So if there are any countries here that want to discuss the hosting of the next conference in 2021, I was going to ask you to raise up your hand, but you can talk to me later. Then we can discuss how much you can put into the organization of this. Diane Gashumba has already said she wants to host it again. So Rwanda wants to have it again, but we'll have to discuss that. Well, I won't spend much time on protocol because this room has so many important people. It's a protocol nightmare. So to try and list them would be impossible. What I would like to say is that my desire for this conference is that we are here as equals concerned about the state of health in Africa, as you saw in the video. Hopeful that though our influence in whatever we do may be different, our insights are of equal value. It doesn't matter whether it's the community health workers, the community member, the Under-Secretary General of the UN, the ministers of health here, policymakers, our insights are of equal value for building the future of Africa. I am impatient, and we must be, ladies and gentlemen. Today is 2019, March. It's 19 years since the launch of the Millennium Development Goals, and it's only 12 years to the end of the SDG period, which is 2030. So we have a shorter period than we've had, and yet we have so much unfinished business for the MDGs. It therefore means that for us to reach 2030 and the goals we've set for ourselves, the speed cannot be the same. So I am impatient, and we've got to be impatient. We know that much gain has been realized, and many lives have been saved through all the programs and projects and activities and initiatives that we've done. However, I would rather have this conference to be a point of reflection, not celebration. The statistics are not good. We know we need to accelerate gains to reduce maternal mortality to achieve what we need to achieve. It cannot be business as usual for the SDGs. We need to ask ourselves a few questions, not least the ones that have been discussed here in the morning, all the way from Professor Cotton's lecture to the plenaries that we've had, to the discussions, and we'll be having many more of these, to ask ourselves why so many are left behind. Why we are unable to jump over the tables and the chairs to reach them. Why there are so many of our people today who are going to die from preventable conditions, from preventable diseases that we could do something about. 30,000 people will enter the poverty bracket today because of health costs. 30,000 in Africa. Today we'll move from $2 to below $2 because of health costs. Some of those are our neighbors. Some of those are our relatives. Some of those are our children, our parents, who will move from where they are to poverty because of health costs. Today, 30,000 in Africa alone. They will sell their land, they'll sell their livestock to pay for health costs. We have stagnated immunization to 74% in Africa, way below the global average. Yet 500,000 children die of vaccine-preventable deaths in Africa a year. Yet immunization is our biggest tool yet to fight premature death. But we are still stagnating. Vulnerable communities, non-resilient health systems. We know the health systems cannot survive a strike of nurses. In Kenya, when we had the nurses strike, and I'm glad that the Cabinet Administrative Secretary for Kenya will be joining us today, immunization dropped by almost more than 10 percentage points in terms of coverage. How can we have such labile, such fragile health systems? Our children are 14 times more likely to die before their 5th birthday in Africa compared to the developed world. 14 times. Today, over 800 families are going to mourn a mother, a sister, a daughter, a wife, a friend, because more than 800 women today in Africa will die of maternal mortality, maternal death, pregnancy-related. Yet, birth of a new life is supposed to be needed, cherished, and celebrated. Health should not be like playing the lottery. But that's what it has become in Africa. That if you are born rich, you win. If you are born poor, you lose. It can't be that way. The last 2 days, we spent time with over 400 young people who are here for the pre-conference on youth, and you're going to be hearing shortly from them about the thoughts that they had at this fantastic conference, which included 16 people who drove in a caravan 1,500 kilometers from Kenya to Kigali because they couldn't afford to fly. But they wanted to attend the conference. And they collected, yes, you can clap for them, which really exemplified the leaving no one behind, the jumping over the barriers. They slept on dormitory floors in Uganda, in Kabale. Their truck broke down, but they collected 400 views from youth along the journey on what youth can do for UHC, and they brought those views to this conference. Where shall we be when our girls go through their lives blind? The girls that we have here as young girls, who we had the last 2 days, blind that they could get pregnant anytime. One of the girls told me, it's just a game of chance. As you grow as an adolescent in Africa, it's a game of chance. You get pregnant, you probably drop out of school. If you're lucky you don't get pregnant, you go through school. It's a game of chance. It's lottery. Because they have no information, they have no access. It's lottery. Where shall we be? Our celebrations must not cloud our challenges. Africa can do better, ladies and gentlemen. The tools exist. People don't die because of lack of science to prevent premature death. They're dying because we have not decided to save them. And we must make that decision at this conference. Universal health coverage is first and foremost not about those we have reached, the overserved. It's about the underserved. And if you want to understand that, and you look at the SDG, and you look at SDG 3.81 and 3.82, they are very clear. They are not about reaching the reached. They are about reaching the unreached. Specifically, 3.82 on financial protection reflects on reaching households that have large household expenditures as a share of their total household income. Those are the ones, they are the ones who are left behind. When we talk about coverage of health service and access, we are talking about reaching the most disadvantaged communities. And the conversation on primary health care is central to this conversation. And for me, to pretend that universal health coverage refers to universalism is to miss the point. It is first and foremost the disadvantaged, those left behind, that we must bring forward first. It's about equity, not equality. We have talked and talked. There are many frameworks that exist across Africa. UHC 2030, we have a framework for achieving UHC. Governments have strategies for UHC. In TCAT 6, which many governments here signed, there's a framework for action that talks about how to go towards UHC. But success has been patchy and far between. In this patchy, far between context, Africa adds 31 million people every year to its population. To an already stretched health system, to already stretched resources, to already stretched resources that cannot give our girls access to sexual and reproductive health services. It's time for action. Welcome to AHAIC 2019, ladies and gentlemen. Over 1,500 people are going to be assembled in Kigali from 47 countries across the world. We don't have enough time to call them all up here. Over 60 partners are going to be with us here, holding different sessions around the conference so that we can all discuss how to save our people in Africa from premature death. I recall a statement I read that says, those with little in life deserve more in law and in practice. They have waited for too long. 2030 is now. To Africa, our continent, viva. Thank you. Ladies and gentlemen, we had invited our colleague and brother, Tedros, who is the Director General of WHO, and he called myself, called Diana, and said, I cannot make it, but I would like to send a video message to all of you. So right now, I'd like to invite you to watch the video message from Director General of WHO, Tedros. I can't say his second name.
Your Excellency, Minister Diane Gashumba, my sister, and Dr. Gitanji Gitai, Excellencies, ladies and gentlemen. Thank you so much for the invitation to speak to you today, and I'm really sorry I can't be with you in person in Kigali. But first of all, I should greet you in Kinyarwanda, Amakuru, Muraho. As the son of Africa, I'm proud to see the progress the continent is making economically and politically, as well as in the health of its people. Between 2000 and 2015, life expectancy in Africa increased by almost 10 years, double the global average. But many challenges remain. As Africa becomes more prosperous, inequalities are growing. Some people can access world-class health care, while millions of others miss out on the most basic services. The best way to ensure everyone can access the health services they need without facing financial hardship is universal health coverage. And the foundation of universal health coverage is strong primary health care, with a focus on promoting health and preventing disease. This is not a job for the health sector alone. All countries must take a whole-of-government approach to address the economic, social, and environmental causes of ill health. In September, world leaders will meet at the United Nations General Assembly for the high-level meeting on universal health coverage. This is a key moment for catalyzing political support for our global movement. I look forward to a day when all the sons and daughters of Africa and all people everywhere get the health care they need, the health care they deserve. And I would like to use this opportunity to thank His Excellency President Paul Kagame for his leadership in improving the health of the continent. The last AU summit was an important example of his leadership. So I say thank you, and I say Murakoze Chane. Thank you.
Well, I'm back to you, ladies and gentlemen. Unlike celebrities who change their attire in 2 minutes, I'm unable to do that, so I'm in the same suit. The reason I'm here is to recognize a champion who has been at the forefront in Africa in championing leadership and accountability for universal health coverage. Many of you here have spoken about Rwanda's success, and we want to create benchmarks for universal health coverage based on framework that exists. So as we prepared for this conference, we used the TCAD 6 UHC for Africa, a framework for action. And looking at that, the organizing committee considered several countries and decided to award His Excellency President Paul Kagame the Universal Health Coverage Presidential Champion Award. When we chose this lion, and I'm going to request my sister, Honorable Minister for Rwanda, to come forward because she's also giving the next speech, so you can come ready. When we chose this lion, we had no idea that actually the symbol for the Rwanda Patriotic Front is a lion. So, please, it was not a political decision. So yes, please, clap. And as I introduce our guest of honor, Dr. Diane Gashumba, for today, and as I hand over this award, please come close to me, I would like to very quickly summarize in one paragraph why the organizing committee decided to award this to His Excellency, President Paul Kagame. In 1994 to 1996, genocide, It had a major impact on government infrastructure, including healthcare facilities. In 1997, the Ministry of Health, with the support of international development organizations, designed and implemented a community-based health insurance CBHI pilot. The CBHI model relied on a community-owned approach to improve health-seeking behavior among the population and eventually led to a better health outcome. Since then, Rwanda has made monumental progress in universalizing health coverage. Rwanda is one of the few developing countries to achieve a near universal insurance coverage, with over 90% of its population covered under the CBHI. This has had its desired impact. The country has seen a 64% decline in the incidence of impoverishment between 2005 and 2010, and a decline of over 50% in terms of catastrophic costs to patients. This has been possible due to a high-level political commitment backed by financial prioritization of health. In 2017, the healthcare budget stood as 15.3% of the total government spending, which is above the 15% Abuja Declaration. This makes it one of the few countries in Africa to achieve the target set under the Abuja Declaration. By employing a people-centric approach and creating a sense of ownership of the health program by the community, as you've seen, and I encourage you to visit the Rwanda Health System. We have visits tomorrow from 10:30 to 12:30, and you can sign up to go to the health facilities and visit and see what we are talking about. By employing this, utilization of healthcare services has increased by 107%. Ladies and gentlemen, it's my great honor now to present this award of the UHC Presidential Champion to His Excellency President Paul Kagame, to the guest of honor, Diane Gashumba. I now give you the guest of honor for this event to officially open this conference, Her Excellency Dr. Diane Gashumba, Minister of Health, Republic of Rwanda. Thank you.
Too emotional. I'm very happy, like Pacific. I'm so happy. Thank you very much. The Executive Director of UNAIDS and Under Secretary General of the United Nations, dear Michel Sidibé, representative of UN family, honorable ministers, sisters and brothers from Africa, members of parliament, WHO delegates, representatives of international and local organizations supporting the Ministry of Health here in Rwanda, CEO and private sector representatives, civil society, youth from all over Africa. On behalf of the government of Rwanda, I would like to welcome you all to this very important event. We are very honored to host you for this year's Africa Health Agenda International Conference here in Rwanda. On behalf of the President of the Republic of Rwanda, His Excellency Paul Kagame, I wish to thank you for this recognition of the Universal Health Coverage Presidential Champion. This award is a recognition of a leader who is really caring for his people. Our president is people-centered, Thank you, Gitinji, for recognizing him. For the Minister of Health, RBC, hospitals, health centers, community health workers operating in Rwanda, our dear partners, this award is a wake-up call. It is a wake-up call that reminds us that we must work harder than ever to ensure that we maintain the success and the gains and exceed the momentum. So wake up. Don't take for granted anything that has been done. We have put much energy, our government has put much energy, our partners has put much energy on this, so we cannot take anything for granted. I want to take this moment to thank AMREF, Rwanda Convention Bureau, the Ministry of Health staff, RBC staff, our dear partners, our students, the Association of Medical Students here in Rwanda, and everyone who has contributed to the preparation of this conference. We are all here because we share the belief that health is a human right, and that every person, everywhere, deserves access to quality health care without suffering financial hardship. These beliefs makes up the universal health coverage movement, which has gained remarkable momentum in recent years and has brought us here today at Africa Health 2019. I believe that this biennial African-led global conference is an important milestone to accelerating progress toward health for all in Africa by 2030. Over the next 3 days, world leaders, technical experts, community members, and other actors from across sectors will engage in critical debates and discussions that will take stock of Africa's most pressing health challenges, as well as assess progress on realizing UHC. I'm very optimistic that through these critical discussions between all of us, we can turn laudable commitment to deliver UHC into tangible actions. This conference comes at a critical point in Africa's pursuit of UHC. Over the past several years, countries across the continent have come to recognize UHC as a smart and achievable goal. 3 years ago in Nairobi, Kenya, African heads of state launched Universal Health Coverage in Africa, a framework for action during the 6th Tokyo International Conference on African Development alongside other stakeholders. Leaders came together at the highest level around the need to strengthen health financing, service delivery, last-mile services, and political leadership in order to realize UHC across Africa. And just last month, at the Africa Union Summit, His Excellency Paul Kagame, the President of the Republic of Rwanda, while handing over as the African Union Chair, convened the Africa Leadership Meeting on investing in health in order to encourage African governments and global partners to translate commitment into measurable actions, align spending with country and continental priorities, and identify efficiencies that will improve millions of lives across the continent. For example, Ghana, Ethiopia, Kenya, South Africa, Morocco, and Senegal have put impressive mechanisms in place to scale up access to health insurance as a means to drive UHC, and very soon Uganda, as said by my sister, Minister of Health from Uganda. Right here in Rwanda, we have developed a near universal health care system that covers more than 90% of the population and is publicly financed by our tax revenue, as well as premium scaled by people income. Though various countries have seen increase in health expenditures since 2001, domestic financing for health has only increased marginally. The growth has instead stemmed from development assistance and out-of-pocket spending. This has unfortunately left many people across Africa with insufficient access to affordable quality healthcare, and it is unfortunate. And when someone cannot pay their healthcare bill, this constitutes a burden for the family, for the community, and for the whole nation. When someone pays their care bill and have to think about making a choice between paying health services, education of the kids, and the basic in the family, it is a huge burden. Unattainably high out-of-pocket payment for healthcare alone push and keep 11 million Africans in poverty every year. What's more, many households in Africa have to borrow money or sell their assets to pay for healthcare, and therefore we must work very hard to overcome this challenge together. The time is now to work together to increase the momentum on universal health coverage across the continent, and as leaders to deliver tangible improvement in our constituents' lives. We can and must act now to ensure quality health care is accessible and affordable for all. Today, I must say that I'm very inspired by the strong political will I see for universal health coverage across Africa and the world. Over 100 low and middle income countries, home to 3/4 of the world population, have taken steps to deliver universal health coverage. And the World Health Organization has made UHC a top priority under Director General Dr. Tedros' leadership. So over the next few days, I encourage you to leverage this unprecedented momentum toward health for all and find innovative solutions and approaches to achieving universal coverage in Africa. Allow me to conclude by requesting a collective effort in addressing challenges in our health system and ensuring accountability and patient safety. Let us all aim at putting the health of our population at the top of our daily agenda. Finally, before I open officially this conference, I want to wish you a very good stay in Rwanda. I want you to enjoy the beauty of our country, and I hope you will stay longer than planned, and I hope to see you very soon coming back for the next UHC conference. Thank you.
Thank you so much, Honorable Minister. And allow me to request you to remain behind and be joined by Dr. Gitinji Gitai and Dr. Ian AHAIC from the WHO. And then lastly, our youth delegates, Marie Claire, to mention to the public that we've had 2 days of a great pre-use conference, and then we're going to discuss some of the outcomes. Thank you. You're welcome.
Good morning, ladies and gentlemen. So we as the youth decided that we do not want our panelists to sit on the chairs because it will make it look a little bit formal. So we'll do it the African way, which is a town hall way, or baraza ya wazee if you're from Kenya. And baraza ya wazee means someone is on the hot seat, and that our staircase is a hot seat today. And I am the unfortunate person who is the judge of this particular case. So in summary, my name is Marie Claire Wangare. I am from Kenya, and I am currently the Secretary General, or in our fancy term, Vice President of Internal Affairs of the International Surgical Students Network. Our panel, or our Baraza of Wazee this morning, is none other than, for starters, our father. We called him Papa Youth for UHC during the Youth Pre-Conference, Dr. Githinji Gitahi. A round of applause for him. What he started is something phenomenal, and I think we as a youth now have a challenge to live up to our father's expectations. Secondly, and most importantly, it's our mother of health, our host, Honorable Diane Gashumba, whose country is really at the forefront of leading the UHC bandwagon, and whom most of our African countries have to emulate. And last but not least, we have, sorry, another round of applause. Last and not least, we always hear policy, policy, all these things you're doing, we have to have nice concrete documents. So finally we have a policy maker, and the policy maker, fortunately, is on the topic of our Council of Elders, Mr. Ian Askew from the World Health Organization, and who deals with sexual reproductive health and rights. Another round of applause. So over the past 2 days, the youth have met in a very youthful way. As you heard, we had a lot of arts, then we also had a lot of science, and at the end of this, we always hear that youth are good at having lively conferences, but what was your outcome of this conference? So this year, we did a modification of what we did in 2017 in Nairobi, and we are developing a position paper. Please note, we are developing. The paper will be developed by the end of the main conference, because we have a group of youth hidden amongst us, listening in on the conversations and taking key inputs from what's going to happen over the next, now in total 1 week, for the youth position paper to be truly reflective of our voice. Unfortunately, we the youth are very good at making noise, so that's why we have this Council of Elders here today to tell us whether we are just writing noise, we are just noise making on paper, or we're writing the right thing to present at the UN high-level meeting. And that is why we have this session, so that we can make it relatable not only to the youth, but also relatable to you, our parents, and our elders and spearheaders in the field. So with that regard, one of the main things we learned is that we are scared about talking about sex. I'll say it louder. We're scared about talking about sex. Yet, sexual reproductive health and rights is a key issue affecting most youth, and Africa has the most youthful population in the continent. So in that regard, we're going to break down our communique with using sex as a topic. And our first question, unfortunately, goes to our father of policy, Mr. Askew. As you heard, we have a huge gap with policy. And our communique had 4 key areas. The first area, of course, is having a table where the youth can come and sit on, or having the opportunity to create our own tables where we can have our voice heard. So we phrase that as inclusion and meaningful youth engagement. So this meaningful youth engagement, our suggestion was, let us create youth advisory panels where we as the youth can discuss issues affecting us and come up with policy. Mr. Askew, do you think we are on the right track, or we are just saying a crazy idea that probably shouldn't be implemented at all based on what is there now?
Well, thank you very much indeed. And I'd like to thank the organizers first for inviting me to participate in this, and also for focusing on sexual and reproductive health and rights. It's not the only health issue for youth, but it's a pretty important one. And I think taking that as a starting point, everything else reflects around that and is determined by sexual and reproductive health and the rights to have the highest levels of sexual and reproductive health. In terms of participation and engagement, absolutely. I mean, there's no doubt about that as a right to engage. But I think the key issue is how best to do that. And one thing is to stand and make a lot of noise, as you say, and get yourselves heard. And the youth are very, very good at that. And we've seen many, many examples. but also the people that they're making the noise to have to listen and respond. And I think I have two comments to make. One is, for people like myself and many in the room with the grey hair, you know, we were all youth at one time. We've been through that, we've experienced it. Never forget what it was like to be a youth. Don't ever forget that, because if you forget that excitement, the energy you have as a youth, the desires you have, the goals, the aims, then you'll understand where the noise comes from and why the noise is being made, because it's your future that you're thinking about, your future that you want to influence. And secondly, for the leaders in the room, you have to look into your own organizations and how you operate to make sure that you can create a space and engage meaningfully youth groups into the way that you work. I'll give two quick examples from my own organization, the World Health Organization. Our leader, Dr. Tedros, has completely revamped the internship program in WHO to really make a lot of space for young people to come, learn experience and contribute to the way that the WHO functions. And this is really changing the way that we work as an organization. And secondly, in my own department, any guideline, any of the normative products that we develop, we have as a policy, we have to have youth representation on the committees, on the expert groups that design and develop the global norms that we put out there. So I'd like to just suggest that we think positively about how can this really happen in different organizations, and for the leaders in the organizations to make it happen.
So the second component of meaningful youth engagement doesn't involve World Health Organization, it also largely involves the government. So the youth decided to suggest that we are tired of always being told, go to your Minister of Health, because we know in some countries it's hard to reach your Minister of Health. It's easier probably to reach your chief, or if you're from Kenya, your county leader. And hence we suggested our second thing under meaningful youth engagement would be using of existing government structures, especially at local government level, to engage in policy making. So our host and our mother, Dr. Diane Gashumba, please could you comment on whether we are on the right track with that suggestion, or we need to fine-tune it a little bit further?
The youth I've seen for the past 3 days are on good track. And I really hope that back in their countries, they go beyond the talk. They will implement the statement they made here, and they will not wait until their leaders, the ministers, the government are calling them on the table. I hope they go and they find a place on the existing tables. Because I've seen march engagement, seeing young people coming, using a caravan from Kenya, stopping in Uganda, collecting views of more than 400 people. This is an engagement. And from the debates we had since the day before yesterday, I can tell those people are really engaged. They just need to be guided. And here in Rwanda, our youth people, I think they are given everything. They have the National Youth Council where they can express their ideas, where they can even initiate policies. They have a Ministry of Youth that is led by a very young woman who was here the day before yesterday. So any policy that is meant for youth starts with youth. And I think the theme of this youth pre-conference was right, very right.
Nothing about us without us.
Without us. So youth in Rwanda, they are given this platform. They have the National Youth Council starting from the village, from the household. They just need to consider this advantage, to consider this opportunity, and deserve the opportunity they are given. They are part of the parliament. They're sitting in the parliament. So it's up to them. And I hope the statement we made together to say no to drug abuse, to say no to new cases of HIV, to say no to alcohol abuse will be put into actions. So you are on good track.
So now this takes me to our second pillar, which is capacity building. The big concern youth had was we are being told to take seats at already existing tables, and some of us learned in places where you might have needed to climb a tree to get internet. Others probably you might have needed to go to the next town to get access to stable internet connection. So of course the skills level amongst the youth is wanting. So Dr. Gitahi, this question goes to you as our father for youth for UHC. What can you advise us, your children? Because we want to engage. We have different levels of skills. We have different attitudes towards how to approach our leaders. Rwanda is saying we have the avenues of engagement, but probably Rwanda's levels of engagement is different from Kenya's, is different from Uganda's. So how can we as youth present a united front and get the necessary skills so as to promote youth for UHC?
Thank you, MC. I think there are two issues to look at, and I think that the first issue is the youth themselves. I look at the youth, then I look at the structures. The youth themselves, as we discussed at the conference, need to think about creating their own spaces. And I think I give the analogy of saying that you can never understand somebody unless you climb into their skin and you walk in it. Meaning that the youth themselves, we can sit here, but we may not understand their actual needs. So the youth need to create their own spaces to bring up these needs, and this may reflect in terms of social participation, and for the youth being active in terms of creating youth movements from the ground. We tend to engage, even here, if I was to ask about the youth who are present in this conference, there'll probably be youth who are already engaging in the global health discussions. They're already the youth who are going to conferences. I don't know how many conferences you went to last year, MC.
I plead the fifth not to comment.
You see, you won't answer because I know there are more than 5, but I've met you in a few of them. Where are the youth who don't attend the conferences? I know that the caravan did collect the views of the youth as they came along, but those are really the ones who are most left behind. How do we include them? How do you, as youth, find a way of including them? So that the conferences is not the place to engage the youth. The place to engage the youth is where the youth are. It is in the rural areas, in the primary schools, in the secondary schools, and driving the agenda for the youth from there. Then lifting and filtering the ideas and bringing them here. So I think the first thing is, how do you as the youth move away from engaging policymakers only at conferences and first going down to the youth so that you bring the real views of the youth? On the other side is to talk about the structures. And the structures is about institutionalization of social participation. I'm aware that WHO right now is working on creating a framework for social participation, because social participation has been a big deal. We know that we sit here and we say we must engage the people must engage, the youth must come on the table, people from vulnerable communities must be here. But how? The question of how is never answered. In some countries, if you look at Iran, you look at Tunisia, they have created what they call the National Health Assemblies. Now, those National Health Assemblies that are running in Iran and some of these countries and Thailand are institutionalized mechanisms of getting the views of the people from the bottom. Many of our countries, if you look at Rwanda, you look at Ethiopia, you look at Uganda, you look at Liberia, you look at Kenya, we have kind of devolved certain level of services. Now, when you devolve those services, you must also devolve the social participation, because the real action happens at the bottom. How do we make sure that the policymakers, the government, provide that structure so that the views are brought up and they are received? And that social participation framework, which is being developed as a public good by WHO, should be released hopefully by September. I'm seeing ASQ is not sure whether, to commit or not, but I am sitting on that hub, and I think we should be able to get it out by September, which then speaks about how should governments create the framework to make sure that the ideas bubble up in an institutionalized manner, and the youth should be part of that. Finally, the youth need to create, you have created a Youth for UHC movement out of the UHC conference, the one that you've had the last few days. Don't kill it, okay? It may be hard, but make sure that it moves on and make sure it engages. Even at UHC 2030 level, we have what we call the civil society engagement mechanism. That UHC for Youth for UHC movement you've created, make sure it comes on the table and becomes a member of the civil society engagement mechanism of UHC 2030, so that even as these frameworks come, you're plugged in from bottom to the top. Thank you.
So, thank you for that. now that you've sort of alluded to what was supposed to be our last pillar, probably that should be, our last pillar was supposed to be investments, and our third one was supposed to be quality services. But because you've already preempted investments, I'd like us to discuss that. So yes, I agree that sometimes it's a youth's own initiative to attend conferences to get these skills, but sometimes we have some youth who are very shy. They have the urge to attend these opportunities, but they don't have the resources. Others just don't know that these avenues are there, and others are looking for avenues of ensuring this conversation goes on. So a key example is, like, unfortunately I'm biased because I'm Kenyan, so I'll give a Kenyan example. The Kenya Healthcare Student Summit. Kenya Healthcare Student Summit happened exactly 1 month ago on the 8th of March. And it started after we attended, Kenya had the biggest delegation. And this is the comedy. We had 1.5 modern coast buses. So that's about 90 people out of 120 traveling by road for 25 hours, Nairobi to Kigali. Kenyans were more than Rwandese by a slight majority. So you will meet a Kenyan, but you will think they're a Rwandese and say, oh, you have a beautiful country, and your fellow Kenyan will switch to Kiswahili and say, I was with you in the bus yesterday, you didn't see me. Some, it got so bad that it was, I was with you in the bus, we were in the same hotel, we were dancing together as Kenya for the cultural show, didn't you see me? So that's why now, the conference was on average $200. We had youth who didn't have that $200. But the conference committee decided, we are youth, let's think out of the box. So they had live streaming of the conference. So you could go to YouTube and see the happenings going on. But we still had people back at home saying, internet is a problem. We can't buy the internet bundles to watch. So now, my question now goes to World Health Organization. You want to work on social participation, but we would like to know as the youth, is what you're planning probably in line with ensuring no one is left behind? Because you see, at every level, you have people who can probably afford a bus ticket or join our caravan and be on the road for 25 hours to come to Kigali for a hike. But then there are others at home who, they are interested, they know this UHC is a thing, they know it's something for health. In Kenya, we had this unit called Geography, History, and Civics. So a friend of mine told me, UHC is now GHC replaced. Just remove the G and put the U. So it's the new hype thing. But what does it mean to me? You know it's out there. We know it's on the internet. But social participation, how am I supposed to participate? So Mr. Askew, please could you advise us further on that concept of social participation? Because it's a big word, but we need it simplified as youth.
Certainly what we've just heard is critically important. Having the voice of youth at international conferences, national conferences, sub-regional, county conferences is important. But the participation has to happen at the community level. And so we have to look at that level to look for the mechanisms for engagement. I'd like to encourage the youth to think beyond the health sector as well, because for most youth, the education sector is the first and most important sector that they engage with as civil society. You go to school, you interact at school, and it's at school where you learn the basics around sex education, if you're lucky. And in many countries, this is still a huge challenge. But I think you can also learn the basics of civil participation at school as well, if it's done well, if it's done correctly. So I think there's a big opportunity for the health sectors and the education sectors to work together much more during those formative years of adolescence to really encourage not only the uptake of good education around sexual and reproductive health and the rights associated with that, but also the rights to participation. And that should be part of a school curriculum, and it should set the basis going forwards for an engagement, not only in health issues, but beyond that. And so that would be my suggestion, to look beyond the glitzy conferences and look to day-to-day life. How can people engage more democratically through the existing processes and through new structures to be created?
Thank you for that. So this next question is for all three of you. I will leave it to your discretion who wants to go first. Yes, there's the aspect of participating, but youth say they need money, whether this is in kind or like being sponsored to attend a conference, or it is actual revenue to start an initiative. They need some form of investments. So could you kindly comment on the role of investments in achieving universal health coverage? Because the youth budget it's always pocket friendly. It's not services friendly. Yes, thank you. Probably I'll start with ladies first. I'm biased.
Mine will be about primary health care. I don't think to access primary health care will require money to youth. And as my colleague has just stated, I think the discussion and the debate and these, for youth to learn, it can start at the village level, it can start at the community level. By engaging with the surrounding community, it should even start at family level. And this doesn't need any funding, external funding or money. Prevention is cheap. I think youth can use this forum, discussing within families, discussing among themselves, and using IT to discover good things, to learn on how they can prevent, avoid some burden, public health issues. And this doesn't require any external funding or support from outside. If we start from there, we preserve our lives, we prevent from drug abuse, HIV, and unintended pregnancies. That is the first step to reach for youth, and then the rest will come. The government will support, local leaders will support. This is the responsibility of each government to fund the health system. But when it comes to primary health care, to prevention, I think it's everyone's responsibility.
Of course, there's the issue of, first, the discussion we are having about service delivery and access and universal health coverage and financial protection. I think the youth must be included in that, because even as we talk about commodities, if you look at hospital attendance, whether outpatient or inpatient, we have a lot of hospital visits when people are young. Then when they get to a certain age, that drops, and there is very low attendance during the adolescent age, and then they start rising again. So the biggest need around there, other than other needs, is sexual reproductive health. The question is whether it's being considered in a structural way in the UHC discussions, so that sexual reproductive health, including commodity supply and security, is part of universal health coverage conversations, is part of the benefit packages that we are creating for universal health coverage, so that youth don't have to worry. And then you think about youth-friendly services. Then you bridge the gap of stigma. On the other side is what my colleague Dan has said about the fact that one of the most important things is to maintain health. What is the role of youth in maintaining health? Now, the role of youth in maintaining health is creating also groups at the village level for themselves to support each other. We know that in security, when villages have really bad security, young people get together and form armies of people who kind of supervise the night for their communities. Why can't the youth do the same for healthcare, that they actually form communities that support each other with or without money? But within the financial protection question, that should be handled in the UHC roadmap.
I'd just quickly like to echo Honourable Minister's point about primary health care as the key structure. And we've heard already from participants, this is a revisiting from 40 years ago when primary health care was first launched. And primary health care with a youth focus, I think, has to be the way to go. Historically, primary health care was seen as free health care, that there was a lot of emphasis on volunteerism, that people were expected to be a community health worker without getting paid. They're supposed to contribute their time for the good of the community. We know that people can't afford to do that. If you're providing a service to the community, you should get the reimbursement. And governments need to invest in that primary level to make sure that the resources are needed to provide the services that people are providing. And we've seen some great examples in this part of the world. Many countries in Eastern Africa have really embraced community health workers as an integral part of the health system and not as a voluntary add-on. And I'd like to extend that and really encourage the primary healthcare approaches to look at them from the age of the primary healthcare workers and really try to build a cadre of young healthcare workers who are going to understand the needs and can be the peers to provide the services in their communities, because we still have a tension between older and younger people in the community with the attitudinal differences and with a younger workforce in the primary healthcare sector. I think that would really help to both empower the youth but also to strengthen the way in which the quality of the service is provided.
Yeah, and maybe encourage the youth that the health sector is and social services is the fastest growing employment sector in the world. So encourage the young people to also enter the health industry, either as community health workers, as auxiliary services, as whatever level. It should be something that they should be conversing about. How do you actually enter the health workforce so that you support yourselves and support the community? Also as a sector for creating jobs so that we resolve the investment issues that you're talking about.
So in the interest of time, our session is over for now. However, we the youth are pro-digital, so we have the draft policy statement online, which we are working on sharing with all the delegates at the conference. Please feel free to give your input to us through our channels for the youth pre-conference at AHAIC Youth if you're on Twitter, or you could just respond to the email that we shall send out. Please, if we kindly request if you could send the input before the 7th of March for us to incorporate it in the final position paper. Thank you very much, and wishing you the lovely remainder of the conference.
Thank you very much. And I request a round of applause, and please let's have a panel picture. Thank you very much. As we take this amazing, we capture this moment. Allow me to welcome you and invite you for the next session. And the next section is actually going to put more light on exactly this discussion that we've been having. As they mentioned, young people are the center. And as I mentioned, young people actually should be on the table discussing the results. So the next session is going to be and build on this session. And without taking further ado, let me welcome our co-moderators for the next session. With no particular order, allow me to welcome Dr. Janine Chondo, who is the Director General of the Rwanda Biomedical Center. A round of applause for the DJ. She's going to be joined by the Executive Director of the UNAIDS at the stage, Mr. Michel Sidibe, and they are going to help us for the next session. Another round of applause for this. Thank you so much.
Janine, comment tu vas? You're trying to after we can start?
Yeah, let's start.
Okay, Janine, you start or I start?
You do.
Okay, thank you very much. Let me just start by saying that the discussion we had was a very important one. Because talking about universal health coverage without putting young people at the center will be just a big mistake. In this continent, we have almost, I can say, 75% of our people are below 35 years old. So we cannot consider them as a passive beneficiaries of our action. They should be actors of change. So I am very happy that you had this discussion, because this discussion is helping us to frame the next discussion. The next one is to really take advantage of what happened in our continent. We know that transformation is happening every single corner. I've been privileged to visit all the countries in this continent. And I can tell you, if you move out of Nairobi and you're going in the village you were describing, you will be surprised to see how resilient communities are there, how they are reorganizing themselves, how they are making sure that they can respond to the demand of their health issues. So it's very important to not lose that perspective, that this resilience. You find them in South Sudan, you find them in Central Republic of Africa, you find them in a different part of the world. And we are seeing also something which is very important, is that you cannot go to scale without innovation. Innovation is happening. And innovation is not happening anymore in the government. Innovation is happening in private sector. We are trying to leverage them. You had this discussion this morning. We know also that it's not possible to go to universal health coverage without social transformation. I was very happy to hear this word. But social transformation means what? It means that we cannot do it with only the ministers who are sitting here. We need really to work out of a government to mobilize the civil society, to bring those non-state actors which will be helping us to transform our delivery approach. And that's why I want to say that what is happening in economic front need to be translated into, of course, more access for people, but access without bringing accountability to the center of the discussion will never be sustainable. We know that we need shared responsibility. We know that we need global solidarity still, but we need really to be result-driven for people who are left behind. That's why the meetings of TICAD in Kenya setting this framework, which has been really well discussed and followed by the framework defined by WHO and World Bank approved, which help us to really give us a guiding, I can say that, principle where we should really work out our next move in terms of service delivery, in terms of financing, but in terms of targeting vulnerable groups where they are, and strengthening health security. All those critical issues have been approached there. Finally, without the political leadership, without proper political choice, will it not be possible. I was so pleased to just have someone coming from this room to say, oh, by the way, you're from Mali. You didn't say that the president of Mali last Monday just launched the universal health coverage reform for Mali. And so I'm sharing that political leadership is key. Without that, we will not make it. So, Janine, please.
Thank you so much, Mr. Michel Sidibe. And I have a question to the audience. I think this is important for us. Do we all agree that universal health coverage is a must-do action?
Yes.
I have the feeling that only the first row is saying yes. How about, how about you there? Do you say yes? All right. But we also know, Michel Sidibe, that it's not one fits.
No.
How do you call it? One size fits all.
Yes.
Meaning we have differences across countries and within countries. So this session, we're going to talk about how each of the country is putting this agenda ahead of time, and how us as the leaders, as a population, as a private sector, we are going to contribute to that. So the Universal Health Coverage Framework for Action represents a powerful commitment to meet the health need of every citizen, without leaving anyone behind. Do you agree with that? Along with the country leadership, political leaders and elected representatives at all levels of governance should be engaged as part of this movement, and we all agree on that too. So in this discussion of this panel today, I would like to invite the esteemed panelists who demonstrated the central role of high-level political leadership in driving key policy reforms to achieve universal health coverage and assure its financial sustainability. Honorable ministers, the representatives gathered on this stage, who are going to be called in a few minutes, have demonstrated unwavering commitment to the vision of universal health coverage. Today we'll take stock of progress since TCAD 6 that Michel Sidibe is referring to, and map a vision for what it will take to achieve universal health coverage in our countries. And I do believe that is possible. It's possible to do it now, and it's possible to do it together without leaving anyone behind. We'd like to thank them, those who are going to join us today for this important discussion. So with your permission, I'd like to invite Honorable Dr. Diane Gashumba. Honorable Dr. Diane Gashumba is the Minister of Health for the Republic of Rwanda. Previously, she was the Minister of Gender and Family Promotion. Dr. Gashumba is a pediatrician by training, and she has been working to promote maternal, newborn, and child health for nearly 2 decades. Please, a round of applause for Dr. Diane Gashumba. Yes. Welcome, Honorable Minister. And also my boss. I know she doesn't like that I say that she's my boss, but she is a very good boss. A round of applause for Dr. Diane Gashumba. Next, we are going to invite Honorable Sarah Aching Opendi. Honorable Sarah Aching Opendi is the State Minister of Health in Uganda, a dynamic leader. You saw it, right? Did you witness that? Yeah, I did as well. She was early working as the Minister of State for Primary Health Care and has been a member of Parliament since 2011. Welcome, Honorable Minister Sarah. Next, we are going to introduce Honorable Dr. Obadia Moyo. Welcome. Honorable Dr. Obadia Moyo is a medical doctor, was appointed as Zimbabwe's Minister of Health and Child Care in September 2018. Before his appointment, he was the CEO of Chitungwiza Hospital. Since 2005, Honorable Dr. Moyo was a founder of the Zimbabwe Kidney Foundation Renal Services, where he served as a chairman and executive director. Do we have? Oh, okay. So next, we have Dr. Rashid Aman. Dr. Rashid Aman. Dr. Rashid Aman is the Chief Administrative Secretary at the Ministry of Health, Kenya, and has been involved in the development of Kenya's Universal Health Coverage pilot program. Prior to working with the Ministry of Health, he has held important positions in the private sector. He's the founder of the Center of Drug Management and the African Center for Clinical Trials. Welcome, Dr. Rashid Aman. Do we have Professor Mangasha? How are you? Professor Mangasha Admasu is the founding executive director of International Primary Healthcare Institute in Ethiopia for the last 3 years, with 8 years of experience working at the university in Ethiopia. Welcome, Professor Mangasha Admasu. Back to you, Mr. CDB.
Oh, thank you very much. I think, Diane, your... Can I? Okay, let me just start with Diane. I think we have been hearing this morning a lot about a community-based approach, Rwanda experience in terms of ensuring community-based health insurance. So could you tell us what, from your perspective, made this experience successful? And what lesson we can learn from that experience which could be shared to other countries? It's working, you don't need to.
I will need a favor from my both here at this panel. I want to introduce my state minister, Dr. Patrick, who is really leading this topic to come to this stage. I think I enjoyed the Baraza ya Wazee some minutes ago. I would like to sit there on the Baraza ya Wazee instead of this. This is not a comfortable seat. So with your permission.
You see? No, you still stay here because we need you. Okay, so go. You're allowed. So, yeah, my brother, so the question is yours now.
Sure, thank you very much.
You know, by the way, I was anticipating that one.
Yes, no, I want to thank you and welcome again for everybody in this room. I want to take this opportunity to share our experience on the community-based insurance. One thing that I want to say, it's doable. It's doable, and it's the right thing to do.
Why is doable?
It's doable. I'll show you why it's doable. We did it.
Yeah.
We did, and it's the right thing to do. But we need to be doing the right thing between the transition from the traditional African solidarity to the modern social security that we want to provide to our people. But this doesn't happen overnight. It's something that takes time. It takes time and it takes patience. And this is not to discourage anybody, but it's not an off-shelf model. One size doesn't fit all, as Janine was saying. And even for countries that have tried it, the model doesn't remain constant over time. Yeah. So you need to permanently be adjusting. And we've seen this happening in Rwanda, the way we started way back in the time, and the model that we currently have is not the same. The starting point, though, for such a model is the political and the popular support and commitment. Without the two together, it cannot be feasible. It's very important that permanently people continue to be re-engaged to see the value of this model. So in Rwanda, as I was saying, we started way back. We continued and developed a pilot in late 90s, did a first model, then adapted the model. And the model has been evolving ever since, and we're still refining it. That was my first point. First point was it takes time, it takes patience, it takes perseverance, it takes consistency. My second point will be talking about the model itself. So the model itself for the community-based insurance, it has to be based on some key principles. And the funding principles here is the solidarity. If everybody is not part of it, then it might not work. Because you might run into what we call adverse selection, where you only have sick people who are in the model. And the philosophy of this thing is people who are healthy should pay for people who are not healthy. People who are wealthy should pay for people who are not that wealthy. It's a solidarity, it's the way we did it. The second key principle for this is the co-payment and the premiums. They have to be set carefully.
Could you explain that? That means what?
Yes, the co-payment, so for any community-based insurance, when we talk about prepayment, you pool some money together to be able to offer services to the people. The fact that you're pooling that money together is translated in each and every person paying a premium, some amount of money. Here in Rwanda, the amount of money is not that much, so it varies between 2,000 Rwandan francs to 7,000 Rwandan francs, which translates to between a little bit less than $2 to $4 approximately. And that money that's put together will allow people to go to the health clinic and get services. But at the same time, because you don't want people to just be walking in and getting services, you ask them to pay a little bit, a little share to the service that they get.
Could you tell us a little bit the result of this experience? What exactly this experience brought to this country?
What it brought
in terms of concrete results?
Concrete results in terms of, one, access to care. The fact that people had a health insurance meant that they could access to care. One quick example in numbers. In 2010, people who were delivering in a health facility were not more than 50%. In 2015, 91% of all the women in Rwanda deliver in a health facility attended by a skilled health professional. That's one. But at the
we can clap on that one.
But at the second thing is that people who are impoverished because of seeking care are reduced, because most of the care is provided. 80% of our population gets care from health centers, 80%, or community health. At a health center, the copay is 200 francs. So when you have your mutual, your community-based insurance...
How you can sustain this model?
The way sustaining it, I tell you, that's why I was telling you that.
And then we move on.
You need to keep adjusting.
Yeah.
So we create a demand, you offer the services, and you keep adjusting. Government puts in more money because we subsidize the model. But at the same time, we make the population and the community realize that they have a share in this action.
Responsibility.
They have that responsibility. But this also goes with what we call the quality of care that you need to provide. If people are not satisfied with the quality of care that you're providing, then they will not access to care. And finally, to conclude, I will say the last thing that's very important is the monitoring of the scheme. Because you need to have the accountability side of it, you need to make the adjustments that are required every time.
If I want to do that, replicate that in Mali, two challenges for me.
One size doesn't fit all, so you need to adjust to the local context. Second, you need to consult with the local people. And third, you need to have the political will and keep consistencies. Because at some point, the other thing, the most important thing, you need to make sure that you have health facilities everywhere. Because if people cannot access the care, if you don't have a very good distribution of your health facilities, it will not work.
Thank you very much.
Thank you very much.
Janine, you...
Yeah. So much, Honorable Moss, Minister of State, Patrick, for the contribution. The next question goes to Dr. Rashid Aman. Dr. Aman, you've been part of the development of the Universal Health Coverage Pilot program in Kenya. This has been launched in 4 countries as part of the Big 4 agenda announced by the President Kenyatta by then. How, in your experience, has the leadership at the highest levels of government been instrumental in rolling out this ambitious program? And also tell us if we need to roll out somewhere else, what will be the challenges? Thank you.
Thank you very much. I would like, first of all, to thank the organizers of this conference for inviting us. It's an honor to be here and to share with you the experiences that we have so far in a very young journey towards UHC. I think we talked about TCAT 6 and the commitments and declarations that were made at that time. TCAT 6, of course, was held in Nairobi in 2016. The government of Kenya came out very strongly in its support for the new health agenda, and particularly UHC. In 2017, as His Excellency the President Uhuru Kenyatta of Kenya was campaigning for his second term, one of his major campaign agendas was universal health care. Shortly after coming into power, the President declared the Big 4 agenda as part of what he wants to focus on, and wants to achieve, hopefully, during the tenure of his second term. One of these big four is achieving universal health care by 2022. I think in terms of political commitment, you couldn't ask for more. It's a president who has given full commitment to the Big Four agenda, and in particular UHC. A president who has made it his lasting legacy to leave power having achieved UHC. So I think in terms of political commitment, we have the greatest political commitment to pursue UHC. We continuously enjoy that commitment, not only from His Excellency the President, but also from the First Lady through various programs that she runs, particularly in maternal health care. Now, I want to just perhaps say a few points about what our journey has been so far. When we started the UHC journey, we looked at many different experiences in different parts of the world. And as has been rightly said here, one size does not fit all. We felt that we needed to do something homegrown, perhaps look at our own context and see how we could start this journey. And we also decided that the best way to begin this journey would be through a pilot program. Can we pilot in certain counties, certain ideas, so that we can be able to see how it works and whether we can pick up lessons as we move on. I think most of you are aware too that in Kenya our health system is a devolved system. Healthcare service delivery is a function of the 47 counties that we have in the country, and as a ministry our role is largely policy setting, providing technical capacity building, guidance and support for the counties. So whatever journey we want to take would be a true partnership between the national government, the county government, and other stakeholders in the healthcare sector. We settled on 4 counties. We initially were looking at an insurance-based UHC system to be channeled through our National Hospital Insurance Fund. We examined and scrutinized the existing operations and systems in place, and including the costs that it would take to establish an insurance-based system. Kenya is a country with about a population of now almost 50 million, and it's only about 20% of the population that is covered by any form of insurance. Of these 20% covered by insurance, about almost 15 to 18% are covered through the National Hospital Insurance Fund, which has various schemes, mostly mandatory schemes through deductions withheld from employees in formal employment, which is the largest section that they cover. They also run some special schemes. But the rest of the population, 80% within the country, have no form of insurance. And really our focus was on these 80% who are the ones who suffer financial catastrophe when they need emergency health services. So we had discussions with our stakeholders, including the counties. We finally settled on a program of providing services without cost throughout the counties. Way back in 2012, the government had already begun that move of removing user fees from health services at the lower levels of level 2 and 3, which is the dispensaries and health centers. The government had also been incrementally introducing programs to support the indigent and the marginalized in form of special subsidies, insurance subsidies that it was providing. For example, the Linda Mama program, which is a maternity program that supports women, pregnant women, during their prenatal, natal, and postnatal periods. So we had already begun a journey in that direction of trying to make health services accessible to most Kenyans by removing the user fees that they were required to pay at the facilities. It was therefore a logical decision then to say, can we remove user fees from the higher levels of service where they access specialized services, which is levels 4 and 5, or the hospitals and the referral hospitals. And that is the direction we took with the 4 counties. We removed the user fees. The government decided that it was going to invest in the health facilities and the health systems within these 4 pilot counties in the form of providing support systems to the counties to build up their health systems, the HR, the financing mechanisms, their leadership, their monitoring and evaluation systems, as well as providing resources that would enable them to be able to access commodities from the Kenya Medical Supplies Authority. So there was some money locked up within KEMSA to be able to supply the counties with commodities through drawing rights that they were given, and they also received some money to help them support their operations and maintenance. This program was launched on the 13th of December in Kisumu, one of the pilot counties, by His Excellency the President, and it has now been running for about close to 3 months. What are the experiences that we are picking out from this pilot? One, I think in terms of registration and trying to get all the residents within the 4 counties registered under a UHC card system, we realized that registration is not an easy process. Registration requires a number of players, including the local government, the national government, and many other players within the communities. And in the 3 months, in the 2 months leading to the launch of UHC, we were able to reach a mark of about 50% registration in each of the 4 counties. 3 months down the line after launch of UHC, I think we are now at a comfortable level of about 75% of all the residents within the 4 counties registered and holding a UHC card that they can use to access services. The lesson there is that registration of individuals for any program that you want to run, whether it is for social protection or for universal health care, needs to be approached very carefully and needs to be given enough time to be able to register and net in those individuals. We found that some of the problems and challenges was that there were many individuals in these counties who had no form of official documentation, whether ID cards or birth certificates or any other form of identification. And we had to devise ways now to be able to surmount those problems. So registration was one of the challenges that we faced, but having gone over that, we have noted that the utilization of services within the 4 counties immediately shot up. And we now currently stand at about 100% increase in utilization of services in all the 4 counties at the various levels. There was an initial surge in utilization of the specialized referral hospitals. And we believe that that was because of the reaction that you normally get when there are services within the available for free, so to speak, that you will get that reaction. It has now stabilized, and I think we are at a good place. The other challenge, and I can see that I'm being reminded that I'm taking extra time, but I think this is important for people to hear, is the commodities. And because the largest investment in this UHC is really the commodities, we are able now to ensure that those commodities actually reach the facilities and reach the people they are intended to, and we're putting in systems to ensure that those commodities are properly used. Thank you very much, and my apology for taking so long.
So Then I think you said it very well. You talked about partnership, leadership, supply chain, and the system overall. So I'll pass the mic to Michelle.
Now, let me just ask to Sarah. Sarah, we know each other for so long time now. I think you have been in so many different positions, leading health reform in some time back in Uganda. But my question is about the role of private sectors. How you're seeing really the private sector playing a critical role in universal health coverage, and which policies or how normative function you will put in place which will help us to have a standardized high-quality services provided by those private sector who want to contribute and need to contribute, because we know that without alternative service delivery system, our own government services will not be able to reach all those people who are left behind. What could be the role? What is your personal...
Thank you very much, Michelle, and it's a pleasure for me to be back here. And just to indicate that achieving universal health coverage really requires a heavy investment, especially in infrastructure, so that we can have services spread all over, so that people can access these services. Fortunately, the government of Uganda, as I did indicate in the previous session, long adopted this primary health care concept. And of course, in adopting the PHC concept, we are now focusing and determined to move on with universal health coverage, so that people can have access to not just health care, but quality health care. And of course, as I speak now, about 86% of the population are within 5-kilometer radius of a health facility. So that implies that people can walk, can be able to move from wherever they are to access healthcare services. However, of course, the challenge still remains in dealing with the other 14%. And already this is something that we're working on as a government, and we hope that by the year 2021, we should be able to cover the entire country so that people have access to health care. Of course, in providing health care in the country, we cannot do this alone as government. The government has been working closely with the private sector. The private sector definitely plays a key role. We have the private for-profit health facilities. We have the private not-for-profit healthcare facilities. And our focus really is on maternal, child health, and the communicable diseases. And we have, as government, been supporting where we don't have government health facilities. The government has been providing some support to these private health facilities so that the services are affordable. And because of this, at least all over the country, people can access services, although in other areas where we don't have government health facilities, they have to pay something, but it is subsidized. And of course, we also have the Private-Public Partnership Act, which was enacted in 2015, and this really has helped us, of course, where government comes in to partner with the private sector in specifically health service delivery. If I can give an example of quality chemicals, CIPLA, now quality chemicals, the government came in, provided the land, of course, we waive off taxes and so on, so that they can be able to produce the essential drugs for malaria, HIV, and others. And of course, we all know that the private sector is key when it comes to innovations. Governments may not focus on these innovations, and where we are talking about promoting digital health, we really need to work closely with the private sector as they come up with these solutions. As government, we need to tap in and see how to use these, whatever solutions they have come with in promoting health.
Are you experimenting already some digital health approach in Uganda, and you can share some of those experiences?
Yes, we have. We have, of course, first of all, the health management information system is in place. You are aware that Uganda is one of those countries where we have been having challenges of the zoonotic diseases and other infectious diseases. So using these innovations, we have real-time reporting. In some areas, we have the VHTs have been given these gadgets, and of course, they regularly, whenever there is any disease, they report to our health surveillance system, and of course, with that timely reporting, we are able to mobilize our teams, and they go down. And that's why you have been seeing that while we've had the Ebola outbreak, the Marburg outbreak, and other viral hemorrhagic fevers, we have not seen, of course, when it came the first time, we had a challenge. We didn't have any systems in place. But with gradually the various innovations, the availability of the phones at the community level, there is timely information passed on to us. And of course, with this, we are able to send our response teams. And of course, this has gradually helped us reduce on case fatalities when it comes to these zoonotic diseases. So the private sector really is key in helping governments achieve the universal health coverage. And I really want to say that also when it comes to health monitoring and all these supervision and so on, we need to work closely with them. But also we should note that in my country, about 50% of health care is provided by the private sector. So this is why we need, as governments, to work closely with them. We normally work with them when we are coming up with various policies. We don't leave them behind. They are key partners. The National Health Insurance has partly taken time to materialize because the private sector was not comfortable, because they also have to make a contribution. So this has been the moving back and forth discussions with them until now we have agreed on what the private sector should really put in when it comes to the National Health Insurance. Because as we talk about universal health coverage, as I said before, we need resources. We need resources, and we need every person to contribute towards health care so that we can be able to provide, or wholly say that Uganda as a country has now achieved 100% universal health coverage.
In most of our countries, at least countries I've been visiting recently, we are faced with a procurement system which is not working properly. It's costly, it's not necessarily helping us to be efficient in terms of going to scale with our services. Do you think private sector can help us there?
Yes, certainly they can, and of course Uganda is no exception. We've been having challenges with these procurement systems. Sometimes they are prolonged, frustrating, but of course over time we have had improvements, of course using innovations, and of course this also helps in reducing on the paperwork, which sometimes is a challenge. So the private sector has also been engaged sometimes in handling some of the procurements, and they do this on our behalf. We've had this happening in cases where we had, I think, Gavi support, Global Fund support. You've had stories around procurement, so I don't want to get into that. But I must really say that as a country, the PPDA, Public Procurement and Disposal Act, is in place that governs procurement in the country. But also, as I did indicate, also the private sector are part of those that sit with us. We have technical working groups, they are engaged in the ministry. We have the health development partners, they are also engaged. So really, I must say that we cannot work as governments alone without the private sector. They are key in promoting innovations, they are key in promoting research, and they can do it better than we in government. So for us as government, our role really is to provide the conducive environment for the private sector to do their work, to complement government's efforts in this health.
Finally, are you seeing a role for faith-based organization to play in this improving this delivery system approach?
Yes, the faith-based organizations actually contribute about 15% to our healthcare delivery in the country. And of course, as government, we acknowledge that these faith-based organizations, where we don't have hospitals, actually they do have. So the government of Uganda also, in this case, provides subsidies to them. We actually give these monies to help them provide free immunization services to the population, like HIV, TB, these are provided free of charge. So in order for them to provide this free service, the government comes in with this subsidy that it does offer to them. So the faith-based organizations are widespread in different parts of the country, and I must say, just like the private not-for-profit, they are under the private not-for-profit, and they actually do a good job. But also on the side of medications, we have the supply chain, we have medicines that we do give to the government facilities. Equally, these private not-for-profit and private health facilities are provided so that they can dispense these medications free.
Thank you very much, Sarah. We can continue. Janine?
Thank you so much. I would like now to call Professor Mangasha Admasu. We all talked about the private sector. We talked about the leadership. We talked about the system. Ethiopia has demonstrated for many years the commitment, the remarkable commitment to achieve universal health coverage. And part of it was due to increasing the health workforce. The question to you is, how do you see the community health workers or community health extension workers playing a key role, pivotal role, to achieve the last mile for universal health coverage?
It's okay. You can speak.
Thank you very much, first of all, for inviting me here at this very important and high-level meeting. Maybe I'm sorry to say, as human being, it is a must to die one day, each of us. The good thing is that we don't know when to die. If we know when to die, we would have not come here. But in reality, it is a must. The most important thing that I want to mention here is, while it is a must to die, do you think that it is a must to be sick? I don't think so. But as if it is a must to be sick, we get sick, all of us. And that's why our worry is here. And this problem is very huge. To the extent now the hospital is there, but people remain out of pocket. Would that not be possible, really, if we have done what we are supposed to do, our job or assignment? Is it a must to be sick? I think we could have saved many of our community without really costing a coin. But the big worry now is people are coming out of pocket. But still it's not late. Even in 1978, 40 years before, that was a big opportunity for us to run and reach. But unfortunately, since then, no single country is successful in primary health care. And what was the atmosphere in Astana? Still, it's to be late than never, so I think we should increase our motive energy and strategy for better health and achieving universal health coverage to save our kids, our youngsters. It is, in our hand. It is therefore, since 1978, Ethiopia, like many other countries in like many other countries in the world, we have been trying to address primary health care. But there were many, many drawbacks, failures, and limitations. So the good thing in 2003, considering the drawbacks that we had before, why we could not retain the health extension, the community health agent, then we called them community health agent. They were trained for 3 months. The training was so short. The trainees were illiterate. They were not able to report. But, taking this lesson in 2003, maternal and child mortality is high. It is a leading problem. It is in the area of reproductive health. So it's good to consider the health extension workers, all females. That cultural shy maybe creates a difficulties during the interview. So if females are going to interview females, that would be good enough. One. The second thing is, all these health extension workers should finish at least 10 grade schools, who can able to read and write, understand the training. The third point is the duration of the training, 1 year, solid 1 year. So the 16 package, the basic health services in the area of maternal and child, infection, prevention, environmental health, hygiene, 16 package. On this training, the fifth point is the local culture, the barrier. So to avoid this thing, this health extension worker needs to be born and grown up in the respective locality so that they will not have any difficulties. The fifth point, definitely they should be paid. Otherwise, we cannot retain them.
Selected from the community, right? But need to be paid. What Ethiopia does to pay and sustain this financial sustainability?
Yeah. So since these health extension workers are 10th grade complete, it's minimally acceptable by the Ministry of Council that they can be employed. So that salary was set unanimously and approved by the Ministry Council, so they are paid. Then 40,000 health extension workers were being graduated in the duration of 2003-2005. Then they start to intervene in the community. Definitely, Ethiopia, as everybody knows, meets MGD 4, 5, and 6 because of the significant contribution of these health extension workers and also the big reform that has been done in the health transformation agenda. This has been recognized internationally. With this, friends of our African countries, then they start to come and share, visiting Ethiopia, what is really the secret behind that successful stories. Before, it was before 2016, for 3 years consecutively, 22 African countries used to come to visit Ethiopia. And not only been introduced, also they used to go to the rural community, what actually is going on at the grassroots level. In fact, it was a good moment, but for the Ministry of Health, in addition to the routine work, hosting the delegates was really been additional work. On the ministry side, on the delegate side, where all delegates really are coming with having a good background to grasp that knowledge, would they stay for some time really to have some important message back home?
Thank you so much. I think we learn a lot from that perspective, that the government should take responsibility in terms of financial sustainability of universal health coverage. Some countries have the system of performance-based financing, others have government paying for salary. So I think this is a very good take-home message for the government, a call for all government here leaders to consider having community focus as one way of reducing the burden for maternal and child health. Thank you so much. So I would like to thank all panelists here. Please join me to give a round of applause to all panelists here who accepted to give their time and commitment, idea sharing, so that we can have that universal health coverage for our population, our next generation. Michel Sidibe.
Thank you, thank you, thank you.
Thank you so much. We're going to request our panelists to remain seated in their seats. And that was really, really a great discussion. And we all feel the urge and the priority of universal health coverage in our different workplaces. So allow me to call upon the group CEO.
I am right here.
Oh,
CEO.
I was trying to actually look in the place where I was like,
he's very fast man.
Take it over.
Thank you very much. You know, the youth called me an honorary youth, so yeah. Thank you very much, the panelists, and a big hand to these panelists. Great stuff. And to Janine and to Michelle for hosting this ministerial panel. We're really grateful. But I want to read a very quick paragraph. In 1993, Ethiopia introduced a new national health policy that aimed to improve health outcomes by increasing its focus on primary healthcare services across the country. This also led to health system strengthening initiatives and a 20-year, 4-stage health sector development plan from 1995 to 2015, resulting in important reforms to the health system. In 2003, as the professor has said, the Health Extension Program, HEP, was launched with a mission to deliver health promotion, disease prevention, and selected curative health services at the community level to achieve universal primary healthcare coverage. One of the key components was to introduce health extension workers who were formalized and institutionalized. Community-based healthcare workers trained to provide 16 packages, including promotive, preventive, and selected curative services. Combined, these initiatives led to improved health outcomes in the community. Under 5 mortality in Ethiopia declined from 166 deaths per thousand to 67 deaths per thousand in 2016. And maternal mortality reduced from 897 per 100,000 live births in 2000 to 353 per 100,000 live births by 2015. In the past years, Ethiopia has displayed strong political commitment to health system strengthening with a focus on improving primary health care, what the Honorable Minister calls highly effective primary health care, by increasing the healthcare workforce and introducing the decentralized model of planning and policy making. Ethiopia has made healthcare delivery people-centered, integral constituent of a strong and robust primary healthcare system. To recognize this achievement, I would now like to invite the Minister of Health in Ethiopia, Dr. Amir. Yes, please. And in line with the recognition of countries that are making progress, action beyond the frameworks that we have discussed, we would like to present this award of PHC for UHC Ministerial Champion Award. Thank you.
So, you didn't describe the animals this time.
Thank you very much.
Thank you.
Because of time, I'll ask the Minister to just make 1 minute remark in acceptance of this award. Thank you very much.
Good morning. I'd like to thank the organizer for this important recognition. On behalf of the Federal Democratic Republic of Ethiopia and the Ministry of Health, I'm humbled and delighted to get this award of Universal Health Coverage Ministerial Champion Award. This award recognizes Ethiopia's successful story of primary health care unit, and also it recognizes all health professionals and our community lead programs, community health workers. We call them health extension program and health extension workers. A special recognition for health extension workers because they traveled more than 20 kilometers per day to reach the unreachables. For our health extension workers, as the poem goes, the mountain is not high enough, the valley is not low enough, the river is not wide enough, and the distance is not far enough for them to reach to our mothers, to our children, and to the community. So please allow me to call Sanait Fisaha, one of our 40,000 hero health extension workers, to come to the stage on behalf of all health extension workers to receive this award and to say a few words.
Good afternoon, and ladies and gentlemen.
ክቡራንና ክቡራት ስሜ ሰናይት ፍስሐ ሲሆን በኢትዮጵያ ጤና ኤክስቴንሽን ባለሙያ ነኝ።
My name is Sanait Fisaha, and I'm working as a health extension program in Ethiopia.
በዚህ ትልቅ ጉባኤ በኢትዮጵያ ጤና ኤክስቴንሽን ባለሙያዎችን ወክዬ በመሳተፌና በሁሉም የጤና ኤክስቴንሽን ባለሙያዎች ስም ይህን እውቅና በማግኘቴ በኢትዮጵያ የጤና ኤክስቴንሽን የሙያ አጋሮቼ ስም አመሰግናለሁ።
It's honored to stand on this international conference on behalf of Ethiopian Health Extension Program. I would like to thank you all of the opportunity and giving us to an AMREF Health Africa and Ethiopian health system too.
የጤና ኤክስቴንሽን ባለሙያ ከመሆኔ በፊት መጀመሪያ በሴቶች የጤና ልማት ሰራዊት አደረጃጀት የልማት ቡድን አባልና መሪ ሆኜ ለ3 ዓመት አገልግያለሁ።
I've been working for 3 years as a health extension program in Ethiopia, and as a first before 3 years service, have been working in Women Development Army in Ethiopia. Has been leading a role to health extension program.
የጤና ኤክስቴንሽን በመቀጠል የጤና ኤክስቴንሽን ማማያ ስላለፍኩ ለአንድ ዓመት የጤና ኤክስቴንሽን ስልጠና ወስጄ በደረጃ 3 ተመረቅኩ።
Have been taken 3 years training program, health extension program, and being graduated in the grade 3 level in Ethiopia.
ስልጠናውን ጨርሼ ስመረቅ ወደ አካባቢዬ ተመልሼ የጤና ኤክስቴንሽን ባለሙያ ሆኜ ሳገለግል ቆይቻለሁ።
After my completion of this training, have been serving as a health extension program. Has been a lot to community level.
የጤና ኤክስቴንሽን ፕሮግራም ዋና ዓላማ ቤተሰብና ማህበረሰብን ማዕከል በማድረግ ፍትሃዊና ጥራት ያለው የጤና አገልግሎት ለሁሉም ህብረተሰብ ማዳረስ ነው።
The main objective of the health extension program is to reach health for all to the community level and the family to the grassroots.
በመቀጠል ለ3 ዓመት በደረጃ 3 ካገለገልኩ በኋላ አፈጻጸሜ ጥሩ ስለነበርና የደረጃ 4 ዲፕሎማ መግቢያ መስፈርት ስላሟላው ለአንድ ዓመት ከ6 ወር ተምሬ በደረጃ 4 ዲፕሎማ ተመርቄያለሁ።
After completing 3 years training program, and I've been graduated in diploma in the health extension program, which is closest to nurse but specialized in the health extension program.
እስካሁን በጤና ኤክስቴንሽን ባለሙያነት በሰራው ስራ ሁሉንም የጤና ኤክስቴንሽን ፓኬጆችን በመተግበር በተለይ እናቶች በጤና ተቋም እንዲወልዱ ህብረተሰቡ የተሻለ መጸዳጃ ቤት እንዲጠቀምና የማህበረሰብ ጤና መድን አባል እንዲሆኑ በማድረግ ሞዴል ቀበሌ መፍጠር ችያለሁ።
Have been implementing this health extension program package which been developed by Ministerial of Health Ethiopia, and I've been serving for more than 3 years for community level, and which is focusing on maternal and child health and helping to mothers to deliver their child at the health center, and helping the community and all the related things, and focus on the PHC, I mean primary health care Ethiopia.
ወደፊት ራሴን በትምህርትና በሙያዬ በማሳደግ በተሻለ የሙያ ኃላፊነት ህብረተሰብን ማገልገል እፈልጋለሁ።
I'm planning to serve my community and my country with this my special health extension program experience, and by developing through education and experience and all matters, and I've been promising this to serve my country.
በዚህ አጋጣሚ ለስራችን ድጋፍ ላደረጉልንና ለሚያደርጉልን መንግስታዊና መንግስታዊ ያልሆኑ አካላት ማመስገን እፈልጋለሁ።
Finally, I would like to thank all the supporters and the partners who have been supporting this health extension program for to come on this stage, and I would like to thank all the giving this opportunity for all of you. Thank you for all.
Sanait Fisaha was a model housewife before she joined the health extension programs. She fulfilled all the health extension package in her household for her children and family. Then she enrolled in health extension program and she became health extension workers. And she became her village a model village of all the countries in Ethiopia. So please give her one round of applause for her achievement. Thank you.
Thank you very much. Please, our panelists still seated. I'm sorry to keep you here for a short moment. Thank you. I'd like to thank
the Honorable Ethiopian Ambassador is here, and so is the Japanese Ambassador. We appreciate your presence here. Thank you very much.
Thank you very much. Yeah, without actually further ado, I'd like to make some housekeeping announcements, and then I'll actually tell why we've actually kept them seated here. So we, first of all, would like to thank all the people, honorable ministers and representatives, the member of parliaments, and the ambassadors that they've just mentioned for their presence and recognize them for this Universal Health Coverage Conference. After that, I also want to recognize the private sector partners and the civil society partners that are all here present. I would like to mention that in the afternoon, there's not going to be anything in this room, but we're going to go in different breakout sessions that are going to happen in the ADs. We have AD1, AD2, AD3, 7, up to 11. So we're going to have that in the afternoon. After here, we have the media team that are going to go in AD11 for a press conference. So please, let's have our ways if we are in the media in AD11. Also want to remind everyone that we are on social media. Please keep tweeting and keep sharing everything that is happening here. So now, I'd like to call upon the ministers to join the moderators and the panelists for a group photo. And of course, the awarded people to join a group photo here. After this group photo, we also invite our partners, the members of parliament, the ambassadors, our partners in the private sector to join a second round of pictures. Right after that, we'd like to invite the ministers, the members of parliament present, and our partners for a closed-door luncheon that is going to take place in the auditorium club. And then we remind everyone to visit the different booths that are just downstairs and see exactly different activities that are taking place in our different countries. Allow me to announce that there was a phone, that is a black iPhone with a black cover that was lost here or in the T-Black. Please, if you find it, you can bring it to the reception of KCC, of Kigali Convention Center. Thank you.